So best drug first, osimertinib in my mind, I think in all of our minds, moves up front. And I think that's very exciting for us. It's very exciting for patients, given all the things that we've highlighted here. So what do we do next? So you get the PFS median of 19 months, and we have some patients who are perhaps on it longer. But the question always comes up, well, I used to know what to do when I was on when I had a patient on erlotinib, it was a cool story. I could do a plasma interrogation of T790M. If it was positive, I could give them osimertinib. We've now moved osimertinib up front now. I think all of us agree with that. What are the next steps? Well, maybe we can start with, what are the mechanisms that we know about, mechanisms of resistance that we know about with osimertinib? And it's not a clear graph like we had with the first or second generation TKI mechanisms of resistance. Alex, any thoughts on that in terms of mechanisms of resistance? And
well, I think Zofia should be talking about this because it was her data that actually has been featured recently with it.
So we'll redirect to Zofia you had some nice work at World Lung that you presented in terms of C797S, but just kind of walk us through some of the mechanisms of resistance.
Yeah, so the first thing I think to say is that most of the work on osimertinib resistance that has been done to date has really been done in patients treated with osimertinib in the second line and beyond setting. Right. So patients who had already developed T790M and acquired resistance to first and second generation EGFR inhibitors. What we don't know yet is what resistance will look like to osimertinib in the frontline setting, although we extrapolate that there will be a lot of overlap with what we've seen in later lines of therapy. In those later lines of therapy, we've seen many of the same resistance mechanisms that we have seen in resistance to first and second generation EGFR inhibitors. But importantly, we've seen a new resistance mutation, the EGFR-C797S mutation, which blocks the covalent bond formation between osimertinib and the target and has been a challenge. We don't yet have the next drug to overcome that, although hopefully we will at some point. As you alluded to, we've looked at the context within which C797S occurs, whether it's on the same allele or in a differing allele than T790M. We've seen that in the majority of patients, it's actually in the cis configuration or on the same allele as T790M, and that's really relevant because in preclinical models that T797S and T790M on the same allele has been refractory to all currently available EGFR inhibitors. We have also seen other bypass pathway activation, for example, MET amplification, which actually may even be a little bit more prevalent after osimertinib than after the first and second generation drugs. In a small cohort of patients from MGH, we've seen that in up to 30% of patients. And that's promising because there are potential options to treat those patients with MET inhibitors on clinical trials, such as the TATTON study, as well as with crizotinib in combination with osimertinib. There's been some published data there. And then, as you alluded to, the rest of that pie chart becomes kind of scattered. Yeah, no. There's lots of different small numbers of things. We've seen BRAF mutations, other things. It's also complicated by the fact that a lot of this data has been done in the plasma, less so in the tissue. And I think the real important question is going to be, what does resistance look like after first-line osimertinib, and how can we overcome that?
Yeah. Since I punted to you, I'm going to jump in and say that I think that beyond looking into drugging these other mechanisms, I think from a practical standpoint, if you have someone that receives first-line osimertinib and then progresses, the answer is chemotherapy. Yeah. And maybe something that's been a little bit more provocative have been the results from the recent platinum pemetrexed and pembrolizumab trial, where it seemed like in a subset analysis, the EGFR mutant patients benefited, but I'll underscore the fact that those were patients that had already had a TKI prior. Yeah. So it may be something that we use, but we might also want to be a little bit more cognizant about potentially emergent toxicities if you give immunotherapy with chemo after a prior TKI. Yeah.
So yeah, just a small correction. This is the EMPOWER trial. It was a carboplatin, paclitaxel, bevacizumab, atezo, which I think showed, well, one of the trials that showed
yes.
The benefit in terms of EGFR and ALK. And I think that regimen needs to be further explored for EGFR mutant lung cancer patients.